Hey, future clinicians. Today we are learning about dementia. This is one of the most important conditions you will see in elderly patients. Many students think dementia is simply memory loss, but dementia affects memory, thinking, behavior, communication, personality, and daily activities. So stay until the end. We will cover the definition, types, treatment, and management of dementia in a simple way. Let's begin. Dementia is a progressive clinical syndrome. Now, what does progressive mean? It means the condition gradually becomes worse over time. It does not happen suddenly. Instead, symptoms slowly develop and become more noticeable over months and years. Many people think dementia only affects memory, but actually it affects much more than that. It can affect memory, it can affect thinking, it can affect reasoning and judgment, it can affect communication, it can even change a person's personality and behavior. Imagine this. An elderly person who once managed their own finances, cooked meals, remembered birthdays, and lived completely independently, slowly starts forgetting important information. They may forget names, forget appointments, become confused in familiar places, and eventually need help with simple daily activities. That is the reality of dementia. As the condition progresses, patients often struggle with daily activities such as washing, dressing, eating, and personal care. Because of this, they gradually become more dependent on family members and caregivers. Now let's talk about the different types of dementia. Do you know, dementia is not a single disease. It is actually a group of conditions that produce similar symptoms. The most common type is Alzheimer's disease. This accounts for most dementia cases worldwide. When people hear the word dementia, Alzheimer's disease is usually what they think about. The second type is vascular dementia. This develops because of problems with blood supply to the brain. Think about the brain like a busy city. Blood vessels are like roads delivering oxygen and nutrients. If those roads become blocked or damaged, parts of the brain cannot work properly. This can eventually lead to vascular dementia. The third type is dementia with Lewy bodies. This occurs because abnormal protein deposits called Lewy bodies accumulate inside brain cells. Patients often experience hallucinations. They may see things that are not really there. Movement problems can also occur. The fourth type is mixed dementia. As the name suggests, this means more than one type of dementia is present at the same time. The most common combination is Alzheimer's disease together with vascular dementia. The fifth type is frontotemporal dementia. This mainly affects personality, behavior, and language. Unlike Alzheimer's disease, it often occurs at a younger age. Now that we understand the different types, let's talk about treatment. A very important point to remember is that the aim of treatment is not simply to cure dementia. Unfortunately, dementia cannot usually be cured. Instead, treatment focuses on helping patients maintain the best possible quality of life. The first goal is to promote independence. We want patients to remain independent for as long as possible. The second goal is to maintain function. That means preserving memory, thinking ability, communication, and daily functioning. The third goal is symptom management. We try to reduce both cognitive symptoms and behavioral symptoms. Before we even discuss medicines, non-drug treatment is extremely important. In fact, many patients benefit significantly from these approaches. One important intervention is cognitive stimulation therapy. Patients with mild to moderate dementia should be offered a structured group cognitive stimulation program. These activities are designed to improve memory, thinking, communication, and problem-solving skills. You can think of it as exercise for the brain. Just as physical exercise keeps muscles active, mental exercises help keep the brain active. Another valuable intervention is group reminiscence therapy. Do you know why old photographs can sometimes make patients smile instantly? Because long-term memories are often preserved better than recent memories. In reminiscence therapy, patients discuss life stories, personal experiences, old photographs, and meaningful memories. This helps improve psychological well-being and helps patients reconnect with important parts of their lives. Next is cognitive rehabilitation. This focuses on helping patients maintain everyday functioning. For example, remembering appointments, following routines, and using memory aids such as calendars, reminder notes, or phone alerts. Occupational therapy is also very important. This helps patients continue activities such as dressing, washing, eating, and household tasks. The goal is simple: help patients stay independent for as long as possible. Now let's move on to management of cognitive symptoms. Here is a very important principle. Some medicines can actually worsen cognition. Therefore, these medicines should be minimized whenever possible. This leads us to something called antimuscarinic or anticholinergic burden. Many commonly prescribed medicines have anticholinergic effects. These effects can cause confusion, worsen memory, and increase cognitive impairment. That is why unnecessary use should be avoided in patients with dementia. Examples include antidepressants such as amitriptyline and paroxetine, antihistamines such as chlorphenamine and promethazine, antipsychotics such as olanzapine and quetiapine, and urinary antispasmodics such as sulfenacin and tolterodine. Now let's discuss Alzheimer's disease management. This is one of the most important exam topics. Drug treatment should only be started under the advice of a specialist experienced in Alzheimer's disease. For patients with mild to moderate Alzheimer's disease, the first-line medicines are acetylcholinesterase inhibitors. These include Donepezil, Galantamine, and Rivastigmine. But why do we use these medicines? To understand that, we need to understand acetylcholine. Acetylcholine is a neurotransmitter that plays a major role in memory, learning, and cognitive function. In Alzheimer's disease, acetylcholine activity becomes reduced. Acetylcholinesterase inhibitors help increase acetylcholine levels in the brain. This can improve symptoms and help maintain cognitive function. Sometimes these medicines cannot be used. Maybe the patient develops side effects, maybe there is intolerance, or maybe there is a contraindication. In these situations, Memantine can be used. For moderate Alzheimer's disease, Memantine is appropriate when acetylcholinesterase inhibitors are not tolerated or contraindicated. Now, here is a very important exam point. The drug of choice for severe Alzheimer's disease is Memantine. Make sure you remember that. Let's look at combination therapy. Imagine a patient is already taking Donepezil, Galantamine, or Rivastigmine. Over time, the disease progresses to moderate or severe Alzheimer's disease. Should we stop the existing medicine? No. Instead, Memantine can be added. Combination therapy should be considered. Another important point is that stopping acetylcholinesterase inhibitors in moderate Alzheimer's disease may lead to significant worsening of cognitive function. Therefore, treatment should not be stopped simply because the disease has become more severe. Now let's move to non-Alzheimer's dementias. For dementia with Lewy bodies, Donepezil and Rivastigmine are preferred for mild to moderate disease. If both are not tolerated, galantamine may be considered. For severe dementia with Lewy bodies, Donepezil or Rivastigmine may still be used. If acetylcholinesterase inhibitors cannot be used, Memantine may be considered. What about vascular dementia? This is another important exam point. Acetylcholinesterase inhibitors and Memantine are not routinely used in vascular dementia. They should only be considered when Alzheimer's disease, Parkinson's disease dementia, or dementia with Lewy bodies is also suspected. Now let's discuss frontotemporal dementia. Students often confuse this area. Acetylcholinesterase inhibitors are not recommended. Memantine is not recommended. The same recommendation applies to cognitive impairment associated with multiple sclerosis. Neither acetylcholinesterase inhibitors nor Memantine are recommended. Now let's discuss management of non-cognitive symptoms. Remember, dementia is not only about memory problems. Patients may also develop agitation, aggression, distress, hallucinations, delusions, anxiety, depression, and sleep disturbances. When a patient becomes agitated or aggressive, many people immediately think about antipsychotics. However, antipsychotics are not the first-line treatment. The first approach should be psychosocial and environmental interventions. This may include counseling, emotional support, family support, reducing noise, providing familiar surroundings, and maintaining regular daily routines. Always ask yourself an important question. Could there be another cause for the behavior? For example, could the patient be in pain? Could there be an infection? Could the patient have delirium? These conditions can worsen behavioral symptoms and should always be investigated. So when should antipsychotics be used? Only if the patient is at risk of harming themselves or harming others, or if severe agitation, hallucinations, or delusions are causing major distress. Now, here is a very important safety warning. The MHRA and CHM have warned that antipsychotics may increase the risk of stroke and death in elderly patients with dementia. Before prescribing an antipsychotic, assess risk factors carefully. Check for a history of stroke. history of transient ischemic attack or TIA, hypertension, diabetes, smoking, and atrial fibrillation. If antipsychotics are required, use the lowest effective dose for the shortest possible duration. Treatment should be reviewed at least every 6 weeks. Another important warning involves dementia with Lewy bodies and Parkinson's disease dementia. These patients may be extremely sensitive to antipsychotic medicines. Antipsychotics may worsen movement symptoms. They can also cause severe antipsychotic sensitivity reactions. Therefore, extreme caution is required. Now let's discuss depression and anxiety. For patients with mild to moderate dementia who have mild to moderate depression or anxiety, psychological therapies are preferred. Examples include cognitive behavioral therapy or CBT, multisensory stimulation, relaxation therapy, and animal-assisted therapy. Antidepressants are generally reserved for patients who have pre-existing severe mental health disorders. Finally, let's talk about sleep disturbances and insomnia. Sleep problems are very common in dementia. However, medicines should not be the first choice. Instead, focus on non-drug approaches. Sleep hygiene education is very important. Patients should maintain a regular sleep schedule, avoid caffeine before bedtime, and ensure a comfortable sleeping environment. Exposure to natural daylight can also help regulate the body's sleep-wake cycle. Increasing exercise and physical activity during the day can improve sleep quality at night. Before we finish, let's do a quick revision. Do you know the most common type of dementia? It is Alzheimer's disease. What are the first-line drugs for mild to moderate Alzheimer's disease? Donepezil, Galantamine, and Rivastigmine. What is the drug of choice for severe Alzheimer's disease? Memantine. Which therapy uses life stories, memories, and old photographs? Reminiscence Therapy. What important risks are associated with antipsychotic use in dementia? An increased risk of stroke and death. How often should antipsychotic treatment be reviewed? At least every 6 weeks. And what is the preferred first treatment for agitation? Psychosocial and environmental interventions. Also remember, acetylcholinesterase inhibitors and Memantine are not recommended in frontotemporal dementia. And that brings us to the end of today's lesson. I hope this video helped you understand dementia in a simple and memorable way. If you found this lesson useful, please like, share, and subscribe. It really helps the channel grow and helps more learners access these lessons. And don't forget, our next video will be on epilepsy and other seizure disorders. So make sure you join me for that lesson. Until then, keep learning, keep revising, and keep becoming a better clinician every day.